Hi friends and subscribers. Today's case is that of a large uterine septum that we have planned for hysteroscopic septal resection using a bipolar resectoscope. So over here on your screen you can see this is a 3D ultrasound that we have done for the patient to identify this septum in the prior month. So over here on the screen you can see a larger zoomed up photo. You can see that the septum extends right from the fundus till the internal os. It's fairly a thick septum, and it is dividing the cavity into right and left halves. These two cavities are quite small in size, and from a fertility perspective are not very useful. This patient has already undergone several cycles outside and is not able to conceive, most probably due to this diminished size of the cavity due to the extremely large and thick uterine septum. It is important that before doing all the septal surgeries you do a nice 3D ultrasound. This 3D ultrasound is ideally done by the surgeon himself or herself, which gives you a very good idea about where these two cavities are. In spite of doing a very good ultrasound this time, you will find that this was a fairly little bit difficult case, and I'll be describing step by step how I ended up doing this, so that this is a teaching video and it teaches you something. Now on your screen I am showing you a completed surgery. This is the post-op image where you can see that the septum has totally disappeared. So let me go ahead and show you how we did this case. We began this case with an operative hysteroscopy. An operative sheath was used to go inside. Here on the screen you can see this is one hole, that this is going to one side of the uterine cavity, and on the left side of the screen you can see this is another cavity. But when I went in, I did not know that the one on the left side was also another cavity. That is because you can see it doesn't really look like a cavity opening. However, this is a little bit fair bit difficult case, and the septum you can see begins right very close to the cervical area. So here we are searching for the other cavity where it is, and then we find nothing. So anyways I enter where I can enter smoothly without hurting, and this is one cavity that I enter. So whether this is the right cavity or the left cavity, at the time of entering into the cavity I did not know. So what we do usually in this case is, since we have a good amount of experience doing these cases again and again, we also use a trans abdominal ultrasound simultaneously. So over here, while doing this from the trans abdominal ultrasound, I came to know that this is the entry into the left side cavity. So once you go inside, you have to wait over there for some few seconds. This allows that the normal saline medium to enter in, dilate the cavity, and you can go inside atraumatically. Remember, if you cause trauma over here, all this fluff that you see on the screen will keep on happening and increasing, and this will decrease your vision and will make already difficult surgery into a very difficult case. So you have to go inside as atraumatically as possible. Have patience in hysteroscopy, which will allow you to negotiate the different cavities quite easily. So here we are giving some fair bit of time for the saline to enter and the cavity to dilate, also to get rid of some of the blood, and then we go inside. You can see that the entry is very smooth, and there we see the ostium. This is the ostium of the left side of the patient. Okay, now since the ostium is very much in the center, you can very much mistake it for the right side of the patient's uterus, but this is the left side. So over here the stuff that you are seeing on the right side of the screen is actually the lateral wall of the uterus, and this entire big thing is the septum. The septum is so thick that it gives you an impression that it's a uterine wall. So now what we have done is, this part you can see is mildly bloody. The reason for that is, first I have put a dilator inside, a small size dilator, the size just like a uterine sound, to find the direction of the other cavity. This is done under trans abdominal sono guidance, and since I know which side the cavity is, I entered it. And here you can see both these cavities. This is the first one which we entered, and left side of the screen is the second cavity that we have entered, and this thick thing right in the center, which gives you the impression that it's the wall of the uterus, is actually the thick septum that we see. This area is very close to the internal os, little bit lower than the internal os, I would say. So now I'm practicing entry into both the cavities and by hearting exactly which is the angle of entry into both sides before beginning the operative hysteroscopy. So here we are going to the right and the left cavity. Again we are confirming this by trans-abdominal ultrasound, which is happening in real time. So now, since I know exactly where to go, we go ahead with the operative sheath. This is the resectoscope, and here this is a bipolar resectoscope which is used for this case, and saline is the distension medium which is used. Here one thing that you should remember when operating on a very large septum like this, there is one thing that you should remember. You should be precise as well as quick with the surgery, because even though you are using saline and not glycine, so it can still cause volume overload and situation like that, especially when the cutting surface, that the surface that you have cut is fairly large. So we have to ideally finish the case within the next 10 minutes to make sure that absolutely there is no worry of any saline overload. So we are beginning with the case over here. Always remember, you have to palpate, that is, you have to first touch the septum and then apply energy. So you will see that first I touch that part and then apply energy. This gives me a very good perspective of what we are cutting, how much fiber is there inside, and hysteroscopic palpation is one of the safety features that you can do. You should make sure the cut is applied exactly in the center from the ceiling to the floor, and the cut is cutting exactly the fibers that you wanted to cut. Also, every cut should only be a few millimeters, because remember, one of the safety features is not to push while applying the current, whereas in this sort of a surgery, that is what you have to do. So when you are pushing the electrode, make sure that you are just cutting a few millimeters at a time. Also, for safety, you have to keep observing the cavity by the side. In this particular case, you will come to know that in spite of removing so much septum, we have still not exactly entered into the main uterine cavity, and you can see darkness on the both sides of the cavity. That means that the fundus is very far away. Remember, hysteroscopes are tinier scopes as compared to laparoscopes, and the light that is shining in is not as much as what you can see in a laparoscope. So darkness gives you an indication that the fundus is far away. So over here we have just reached the area where you would be performing your cesarean section, and still you can see that the cavity is still far away. Now you can also notice, if you are very observant, that the cavity curves ceilingwards, means it is not a straight cut that you can keep on doing, because this particular uterus was curving upwards. So this is where we are applying the current stepwise, little by little, and as you go ahead, now you can sort of see that the cavity has started illuminating itself. So now you are closer to the fundus than before. So you have to make sure that you are at the same level right from the right side of the screen to the left side of the screen. This can be assured only with palpation. So always, if you are very observant, you will notice that I always touch the tissue before going ahead with applying energy. So there is half a second worth of just palpation followed by energy. Again, looking at my depth. So here I am taking my time to judge how much more length is to be cut till we reach the proper fundus. Another safety tool that I am using side by side, which I am not showing on the screen, is the trans-abdominal ultrasound that is going on simultaneously. This is allowing me to judge how much distance is left to the fundus, and it helps me not to perforate the uterus at any point. So as we go ahead, we can see that the fundus is more visible, and the darkness is now lesser and lesser as we go ahead. So we are seeing that we are on the same level on both sides, but always what happens is one side is always lesser. So here you can see that the left side of the screen has more darkness as compared to right side. That is because we are at a higher level on the right side of the screen as compared to the left side of the screen. So we are doing a little bit more resection on this side so as to reach the same level. So now you can see that the lighting is improving on the left side of the screen as well. So that means that you have reached the fundus. So over here now all that we have to do is make sure that the depth of cutting of the septum is even on right as well as the left side. Now you can see we have already reached the fundus and just required to apply a few finishing touches. You can see the ostium quite well, and you can see right there, that's the ostium. So I believe on the left side of the screen our resection is almost complete. We have to just match the level, and again on the right hand side of the screen we are again palpating to find out what is the depth. It is almost there, just a few millimeters, and we have reached the ostium. Now we just have to match the level. This is done by palpating and making sure that we are at the same depth on all sides. Also real-time trans-abdominal ultrasound is helping me. Our staff is very well trained that they give me a real-time perspective of trans-abdominal perspective of what is going on. Here I find that this chunk can be removed. So using this same resectoscope we can just give very gentle bursts of energy to get rid of this chunk, and you will notice the moment this chunk was released there is a lot of cavity that we have, and at this moment we feel that we have finished the procedure and we are coming out. So here we are taking a small breather. We are assessing the case using the ultrasound as well as planning the further steps. So now I am showing, now my recorder was full, so I am just showing a diagnostic scopy which I am doing, but however I am doing this diagnostic scopy with the resectoscope just to understand whether the completion is adequate or not. One thing is, the moment you stop doing the resectoscopy, you will notice that there is quite a lot of vaginal bleeding that takes place, because a lot of the septum is bare area. You may see on the screen that it's not bleeding, but however this is due to the pressure of the saline. The moment the pressure reduces, the blood starts pouring in. To reduce this, it's a very good idea to give tranexamic acid to the patient, as well as give a little bit of methergine or oxytocin. On your screen you can see what I was seeing using the transabdominal ultrasound and a TVS which was done before this step. So you can see that the completion is already done and a few bursts are given as per the palpation. So here you can see that the depth of the resection is the same on both the sides. A case like this always is a two-step procedure where you have to repeat this diagnostic hysteroscopy after a month or after almost 3 to 4 months. This is because the septum grows back. So here is the picture that you are seeing pre-op on the screen. This is a 3D ultrasound picture. You can see the thick septum, and also to compare with by the side you can see the completed picture. Following the surgery, we place a copper T device to keep it as an adhesion barrier. I hope you like this video. Please do like and subscribe, and please comment in case there are any questions. Thank you.